Dr. Badr Alahmari, and he's going to talk about AML focus on menin inhibitors.
All right, Assalamu alaikum. Good afternoon again. All right, thank you for the organizer to invite me to present this talk that has been assigned to me. So it's good to talk for the first time about AML without mentioning 7+3 and FLAG-IDA and others. So we're going to talk about only targeted therapy here, and with the focus on menin inhibitor. So as we know that acute myeloid leukemia is one of the first cancer ever get sequenced, and it is very heterogeneous with complex molecular background with acute myeloid leukemia. Common mutations are FLT3, NPM1 considered to be one of the most common mutations with acute myeloid leukemia, but it's associated with other multiple structural cytogenetic abnormality and molecular operation. We depend on the molecular data. We use them for classification of acute myeloid leukemia, and also we use them for risk stratification. So we risk stratify patients with acute myeloid leukemia based on their molecular data to favorable, intermediate, and adverse. ELN-22 risk stratification based solely for those who received intensive therapy, but also even for those who received less intense therapy, we still can classify those patients on their molecular profiling using a handful of molecular gene mutation to classify those patients. But the most important thing is, can we do this even not only for classification, risk stratification, but also as a targeted therapy and kind of precision medicine? And that's what we're going to talk about it today. So we'll focus on NPM1 mutated AML and also KMT2 rearranged AML, where this kind of leukemia that can be targeted by the use of menin inhibitor. So NPM1 is, again, within the NPM1 leukemia, it's very heterogeneous leukemia itself. So we can have different outcome for patients with NPM1 mutation. It's highly associated with the co-mutation. The most common co-mutated genes with NPM1 is FLT3, ITD, followed by TNMT3A2 and IDH1 and 2. And different other mutation, but those are the most common associated co-mutation. So what's the difference there? Because we can still have different outcome depending on the co-mutation. We know that NPM1 without FLT3 consider favorable risk regardless of the other genes, but also if there is NPM1 and FLT3 ITD, it's considered to be intermediate risk according to the ELN criteria. However, this has been challenged based on the recent data from the Harmony. Harmony study or Harmony registry is a big registry based on in Europe, which constitutes at least 6,000 of AML patients. So they extracted only patients with NPM1 mutation, around 1,000 patients, and they look into their different outcome based on the co-mutational status, and they were able to generate a new risk stratification based on very few number of co-mutations, and you can classify patient within the NPM1 mutated patient into intermediate, favorable, intermediate, and adverse. For example, patient with triple mutation, which is NPM1, FLT3 ITD, and DNMT3A, consider an adverse risk disease, and transplantation in the first remission, probably it's justified in this scenario. So although NPM1 looks favorable, however, for relapse refractory, there is a different story. Patient with NPM1 mutated, once they get relapsed, there are no difference between their outcome of NPM1 mutated patient versus non-NPM1 mutated patient or wild type NPM1. So indicating really an unmet need for relapse refractory NPM1 mutated patient. This is a nice data illustrated from MD Anderson. What about KMT2? KMT2 rearrangement, we can see it in different kind of leukemia. We see it in AML, ALL, mixed phenotype, but with a different percentage. For example, infantile ALL, up to 80% they are KMT2 rearranged and associated with better outcome compared to what we see with other kind of leukemia. Adult ALL, around 5 to 15% of cases. In acute myeloid leukemia, around 6% of cases, especially the de novo. But we see KMT2 rearrangement in patients with secondary or therapy-related AML up to 10%. We know that this is associated with topoisomerase 2 inhibitor, and we can see this after like 1 to 2 years post topoisomerase 2 inhibitor chemotherapy exposure. There are more than different partner, translocation partner we can see with the KMT2 rearrangement. The most common one is MLLT3, which is at chromosome 9, and this is the most common than the one that we see. It is associated classically or traditionally known to be associated with probably a little bit better outcome than other partner. The most common partner with ALL is different, which is the one in chromosome 6. Again, data from the Harmony registry, the European-based registry, they extracted patients with KMT2. They found that it is only 3 to 6% of all AML cases in Europe. They are actually KMT2 rearranged. And then they try to extract their data and analyze them. And what they found that the most common co-mutation is actually NRAS and KRAS mutation. These are the most common co-mutated, and also followed by FLT3 TKD. And within even the KMT2 itself, the co-mutation also play a major role. If there is TP53 or NRAS mutation, this was actually associated with worse outcome in combination with KMT2. And you can see here that KMT2 rearrangement associated with poor outcome, even from the upfront, with the use of upfront setting. And you can see, specifically for this data, there was, which is something new, there was no actually difference between 9/11 translocation versus others. In acute lymphoblastic leukemia, KMT2 also associated with poor outcome with increased risk of relapse. However, there was recent data from MD Anderson showing that incorporation of immunotherapy with the upfront treatment, including blinatumomab and the inotuzumab, was associated with improvement outcome and obliterate the adverse risk of KMT2 in upfront setting. All right, so how we can target KMT2 rearranged and NPM1 mutated AML? The target will be Menin. So in normal cellular components, the KMT2 is actually work as an epigenetic regulator that binds to the chromatin to regulate box gene, but to be able to bind, it needs Menin to help the KMT2 to bind into the chromatin and regulate box gene. Box gene and other set of genes actually responsible about maintenance of normal hematopoiesis. So what happened with the KMT2 rearrangement, that the KMT2 rearranged molecule which binds with the Menin, it's actually upregulates box gene and lead to uncontrolled dysregulated hematopoiesis and differentiation arrest, and that's what happened. For the NPM1, it can interact with the normal KMT2 and Menin complex and make it behave like if it's KMT2 rearranged, again upregulate the box gene and other set of gene and lead to dysregulated hematopoiesis. So whenever you introduce a Menin inhibitor to control the Menin itself and remove Menin from the equation, there will be no interaction between either the normal KMT2 in case of NPM1 mutated or the KMT2 rearranged with the box gene. So you will restore the normal hematopoiesis and stop the differentiation arrest. So far, up to date, there are 2 Menin inhibitors that are US FDA approved. We have revumenib, approved in 2024, initially for any KMT2 rearranged leukemia in general, including pediatric population, and subsequently it was approved for NPM1 positive acute myeloid leukemia. Ziftomenib is another agent that is approved only for relapsed refractory NPM1 mutated acute myeloid leukemia as a monotherapy. So we have two agents. So what are the data that led to the approval? Starting by Augment trial that tested ALL and AML patient, KMT2 rearranged and NPM1 rearranged, but I will try to separate them for you. So initially, the KMT2 rearranged acute leukemia. This is a phase 1 and then phase 2 study using revumenib as a single agent, population median age 34, primary refractory 24, and AML was 80% of cases. Very few cases of ALL, only 12% of cases they are ALL. Again, most common translocation 911. RAS mutation is the most common associated gene, but most importantly that around half of patients, they have at least 3 and more line of therapy, and half of patients at least, they have prior allogenic stem cell transplant, and 70% of patients, they are actually exposed already to venetoclax, so they are refractory to venetoclax, indicating a heavily pretreated population. This has resulted in overall response rate of 63%, CR plus CRh around 22% for this heavily pretreated population of KMT2 rearranged leukemia. And we'll talk about median duration of CR/CRh was actually 6.4 months. And there was some MRD negativity. Around 70% of patients, they achieve MRD negativity. Looking into the median duration of response, as I mentioned, 6.4 months, and median overall survival, 8 months. Not a great numbers, but for some like KMT2 rearranged leukemia with heavily pretreated population, indicating that there are some signal there that this is a treatment that can work for this heavily pretreated population. For NPM1 mutation, extracted data from Augment 101 study, the efficacy population was 64 patients enrolled into this efficacy. They analyzed in this efficacy population with an overall response rate of 47% and CR/CRh around 23.4%. Within this population, around 70% of patients, they have prior transplant, 1/3 of patients, they have 3 or more lines of therapy, and 70% they are venetoclax exposed population, and IDH1 and IDH2 population were within this set of patients. FLT3 ITD, or around 1/3 of patients. And speaking about response were equal. However, patients with IDH1 and IDH2, they show the better responders. In terms of safety, for this, for revumenib, less than 5% of treated patients lead to treatment discontinuation. So this is really significant, indicating that the treatment is not really toxic, as we see with different agents in leukemia setting. Around 20% of patients, they have more than grade 3 or more QT prolongation. So this is something we need to be aware of. Differentiation syndrome can happen. Grade 3 and more, 13% is a significant percentage, indicating someone who already have symptoms requiring oxygen and need discontinuation and intervention at this stage. Febrile neutropenia, 13%, compared with, for example, with venetoclax, much favorable. Duration of response was 4.7 months, the median duration of response, EFS 3 months, and overall survival was median was 4 months. What about ziftomenib? Ziftomenib, again, tested for NPM1 and KMT2 relapsed refractory as a monotherapy. And you can see the initial data showing that ziftomenib might not be as good as what we see with revumenib. And you can see the gray bars. These are the KMT2. So it didn't really work well with KMT2 rearranged leukemia. So it's primarily approved for NPM1 mutated acute myeloid leukemia. This is the data from phase 1, phase 2 study, the COMET 001. Enrolled 92 patients, median age 69. Around half of patients, they are FLT3 ITD population. 24% of patients, they have previous transplant, and 60% they are exposed to venetoclax previously. 1/3 of patients, they have at least 3 and more lines of therapy. Again, a pretty heavily treated population. In terms of adverse effects, as we saw with the revumenib, there are risks of QT prolongation, probably to the lesser degree when compared with revumenib, but differentiation syndrome is still there. Febrile neutropenia at around 26%. Cytopenia is there, but not really significant as what we see with other agents. Can we advance the slide? Okay, that's fine. Okay. So looking into responses, the CR rate was 14%, and CR/CRh was 22%, and the median time to first response was 2.8 months, 60% MRD negativity. And if you look to the duration of response, the median duration of response was 4.6 months, a little bit equivalent to the revumenib, and median overall survival was 6.6 months. All right, so now we'll move quickly to the menin inhibitor in combination with other agent. We have a combination of revumenib with AZA venetoclax in newly diagnosed newly diagnosed NPM1 positive and KMT2 rearranged AML. And this is the schema that they use, which is the standard AZA-ven plus revumenib. And you can see the responses here. The overall response rate or composite CR is around 81%. Which is a little bit higher than what we see with the standard AZA venetoclax alone. And responses were seen across different patient population. And you can see even the responses are a little bit higher and better quality of responses we see with the KMT2 rearranged rather than NPM1 mutated AML. So indicating that the combination might be, will be a future for KMT2 rearranged and NPM1 mutated patient. Median overall survival was 18 months for KMT2 rearranged leukemia in newly diagnosed and 15 months in NPM1 mutated patient. Another study that was presented during the last ASH, which is the SAFE trial. This is a triplet combination using only oral medication, so oral revumenib, oral decitabine, and oral venetoclax. So this is an oral triplet combination in newly diagnosed AML with KMT2 rearranged and NPM1 mutation. Very few number of patients, only 14 patients NPM1 positive and 7 of KMT2 rearranged. Very small number of patients, but there was a good signal here, including high overall response rate of 86% and high CR rate of 76%. Again, this is only a combination of oral regimen with a median, with the overall survival at median was not reached, but overall survival at 12 months was 57%. I think this is my last slide. The menin inhibitor data that was presented during the previous EHA and previous ASH. Here are some updates. For example, for ziftomenib, combination with AZA venetoclax was tested in the relapse refractory and also in the newly diagnosed NPM1 AML. Again, you can see that there is a high overall response rate, 89%, and high CR rate of 76%. Bleximenib was also presented in a Camelot trial in relapse refractory setting. The overall response rate is also still equivalent, 47%, but the CR rate is somehow better than revumenib and ziftomenib as a single agent, as a monotherapy. In a combination, we can also see a newly diagnosed NPM1, a very high overall response rate at 93%. But also in the relapse refractory, we can see a 91% overall response rate in relapse refractory setting with the use of this combination. Also, it was combined with the 7+3. Enzomenib as well is the latest one was presented at the ASH 2025, showing a relapse refractory an overall response rate of 73% as a monotherapy, which is compared favorable to the previous two agents, with a CR/CR rate of 40%. So key points, so at present we have 2 menin inhibitor approved by US FDA, ziftomenib and refumenib, and refumenib approved for KMT2 rearranged and NPM1 mutated patients. Ziftomenib is only approved for NPM1 mutated patients. Monotherapy demonstrates some favorable responses, but they are not really durable. I think the combination strategy is going to be the key over the next few years. What's the best way to combine them with other agents, whether the use of aza-venetoclax or more recently the oral decitabine with the venetoclax that was approved recently for acute myeloid leukemia. And with that, I conclude and happy to take any questions. Thank you for your attention.
Thank you, Dr. Badr, for this nice review of menin inhibitors and AML. Now, these data are very much expected. You know, the usual like we have experience with FLT3 inhibitors. So the targeted agents, they have activity against, you know, the relapsed refractory or even newly diagnosed patients, but that is, you know, limited activity, and the duration of responses are usually not long-lasting. So combination therapy obviously is very much, you know, the promising. One question, which is usually the next step in these patients, is, are you aware of any studies using these agents as a maintenance post-transplant? So patients who had NPM1 mutation and they relapsed and had a transplant, or KMT2A inhibitors as a mutation and they had a transplant. Are there any studies of menin inhibitors as a maintenance?
I'm not aware about specifically for maintenance, but they do allow patients who go into transplant to continue the use of revumenib. But I'm not aware about specific study for maintenance.
I think that will be interesting to see, you know, in future, because theoretically that will help these patients and they may reduce the relapses post-transplant, but we have to see the trial data. So we have time maybe just for one last question.
Dr. Badr, thank you for your elegant lecture. My question about MBM1 doesn't seem all the patients the same. What is your experience with MBM1 mutation patient? How they respond?
Yeah, I agree with you. I mean, as I mentioned, that NPM1 is within itself is a heterogeneous disease. You can see different outcome with the NPM1 mutated patient. What we know of is the associated FLT3 associated with less outcome compared with wild type FLT3. But again, the Harmony data clearly showed that the co-mutation is a big deal here, and I think it produced different outcome with the NPM1. So we have to be careful when to decide about transplant for NPM1 mutated patient. I'm not sure about the next ELN update. Are they going to really rely heavily on the data from the Harmony study or not? But to be honest, we've known this since a long time. Even the paper in the New England Journal of Medicine 2016 of Papa Emmanuel showing clearly that NPM1 influenced heavily by the co-mutation status.
The other questions about the field moving now from conventional chemotherapy to targeted therapy such as menin inhibitors. So what about the MRD in this regard? They are using we are just focusing on morphology. So what about the mutation itself by MRD, NGS, and PCR?
Yeah, as I mentioned, there was high MRD negativity associated, and this was one of the things that they were following, like using the KMT2 fusion protein as an MRD, and also the NPM1, the mutant allele as an MRD. And there were higher MRD negativity, 60-70% of patients in the combination therapy, up to 80% MRD negativity. So I think this will play a role in the future to determine what will be the next step, whether to go for transplant or not, as we already know with the intensive care therapy.
Thank you very much.
Thank you.